starting with observation. So for observation, I'm going to be looking for any visible edema along the spine and cervical area and in the lumbar, looking for moles, scars, or other factors that may affect the nervous scope when doing the instrumentation portion. This button back here, turn it on, and we're going to make sure the sensitivity is set to medium, which is right in the middle. Then we're going to set the arms appropriately for the level of the spine. So for cervical spine, it's going to be a little bit tighter, and for the thoracic spine, it's going to be a little bit wider. And we're going to keep the needles perpendicular to the skin without letting any air get in, and slight depression in the skin when we push down. As you can see, the needle moves. So I'm going to tighten it for the cervical spine, starting around T1 and moving upwards, and looking for a break in the needle as we go up. There's a slight break in the needle to the right toward the top. So we're going to check it again. Slight break. And we do it a total of 3 times to make sure we're getting the same break each time. Then we'll move down to the thoracic, and we're going to go down. Mark below the needles in the cervical spine because we're moving up. When we go down the thoracic spine after I widen them appropriately and we want to stay centered, we're going to mark above whenever we find a break in the needle. So I'll go down and demonstrate as we move down. Staying perpendicular to the skin the entire time. And it looked to be as there was a break in the line toward the bottom, but we're just going to do an assessment in 3 times to make sure. And that's how you. Now I'm going to do the static palpation portion, looking for edema in the all the way down the whole spine, starting with the cervical spine. I'm going to do a general scan, and hypothetically, places that are having issues will have a bogginess or a squishy feel, and associated with edema. And what I would do is, say there's a little bit of squishiness here, I would push on the inferior tip of the spinous process, and usually this would produce pain. We'll go down to the SI joints now, do the upper portion, lower portion, and tenderness at the upper portion of the PI would mean a PI, tenderness at the lower portion might mean AS. The whole joint on one side could be an EX, and if there's no pain, but there is deep inguinal pain, then that could indicate an IN. Now we're doing the motion palpation portion of the occiput, and we're going to go to the mastoid of C0 and the TVP of C1. We're going to laterally flex the patient's head and feel if the mastoid closes down on C1, and if it does, there's no issue. We'll go to the other side and laterally flex the head, doing the same segmental contact points. If it does not close, then we have a listing of an LS or an RS. In this case, we would say LS if it doesn't close on the left side. Now we're doing P to A glide for the occiput. Contact of this is the thenar, the calcaneal portion of each hand, posterior superior to the patient's ear on the supramastoid ridge, approximately at the posterior parietal bones near lambdoidal suture. We have to isolate the side of interest, so we roll the head to the right or left based on lateral tilt while not bending the neck. So we're going to do P to A glide, so come here, supramastoid ridge, laterally flex the neck, and spring in play. Then we're going to switch to the left side and do the same thing, just laterally bending the occiput. And lack of in play will indicate a PS occiput on either side. Okay, now we're going to do A to P glide. We're going to use the hand of the side that we were testing, use a soft pisiform or hypothenar of the supraorbital ridge on that side. We're going to isolate the side of interest, and we're going to roll the head to the right or left based on lateral tilt. We're going to pull A to P for springy in play, and lack of in play indicates an AS occiput on that side. And that's what that'll look like. Go to the left. Okay, now we're going to do posterior anterior rotation. Doctor's contact between the mastoid and the TVP of the atlas, and the doctor will rotate the head away from the side, and this is subtle, and we'll feel for the mastoid to move forward. Lack of movement indicates posterior side of occiput. We can apply this information to the listing side, RP or RA, or LP or LA. If the listing's on the right, but the left mastoid is posterior, The listing side is right anterior. Now we're going to do the atlas with lateral tilt. Doctor contacts between the tips of the C1 and C2 TVPs. Doctor laterally flexes the patient's head, and the TVPs on the side of lateral tilt should close down. If not, C1, C2 atlas is lateral to that side, which is right or left. Okay. And now we're going to do posterior to anterior movement. Doctor contacts posterior lateral arches of the atlas and rotates the patient's face away from the contact side. So I'll be on the right, rotating left, and then on the left, rotating right. The doctor pushes P to A on the atlas contact. Restriction indicates posterior side of atlas. Apply the information to the listing side, and if the listing's on the right, but the left side of the atlas is posterior, the listing is anterior. Showing superior to inferior observation of the patient standing head-neck relationship. So she's going to close her eyes and tilt her head up and down several times until I say stop. Okay, and stop. Chin high or head forward is likely an AS, and chin low or head translated posterior is likely an AI. So now we're doing posteriority. We're going to have the patient flex first, flex forward, and then extend back with the fingertips on the spinous, and the spinuses should separate. If they do not, then the upper segment is posterior. So now we're going to do rotation. Middle finger contacting the segment, and the index finger and the chiropractic index finger, the ring finger are going to be on the segment above and below. And what we're going to do is we're going to rotate the patient to the left and right. And if the segments do not separate, the nose points to the listing, which is right or left. If the patient is rotating to right, there's limited movement, then the patient is a PR. They should stay stacked or move all together. So for lateral wedge, we're going to do the doctor's finger contacting the spine, above and below involved segment, and patient flexes to the left and right, and the doctor should feel a curve in the spine. If it feels flat or vertebra remains stacked, then the open wedge is on the side toward which the patient is leaning. Now I'm doing the sacrum and SI portion of the video. We're going to figure out which side it is on first, and we're going to contact the SI joint. The if is going to be on the PSIS, and our chiropractic index finger is going to be on the sacrum. And we're going to have the patient rotate their shoulder back on the ipsilateral side, and this should produce movement in the sacrum. And if not, then you're contacting the subluxated ilium. Then we're going to switch sides and do the same thing. And then we're going to have the patient stand up, and we're going to do bending. Just that way. And we're going to have the thumbs on the PSIS and have the patient bend forward. And the side that moves up first and stays higher is the subluxated side. And if we have a wobble, uneven early, but then even at the end, seems to indicate sacrum. Observation for a PI or AS. Observation in the bottom edge of the gluteal muscle, bearing muscle, atrophy, or short leg. So a high glute would indicate an AS ilium, and a low glute would indicate a PI ilium. Now we're going to do the mechanical portion, which is the high knee test. One of the doctor's thumbs will be placed on the PSIS, and the other thumb will be placed on the sacral tubercle. The patient raises their head on the same side. Go ahead and lift this leg. And the thumb on the ilium should move slightly posterior inferior relative to the sacral contact. If not, it's an AS ilium. Now the patient will lay the opposite leg, and the thumb on the sacrum should move inferior relative to the ilium contact. If not, it's a PI ilium on involved side, with a lack of PA glide on involved side. Do an EX or IN portion. Observation will be a narrow glute will be an EX, and a wide glute will be an IN relative to the midline. Now we're going to do the mechanical portion. We'll have the patient seated on the first half of the chair. If you can go ahead and sit down. And the patient has, the doctor has one finger on the involved SI, tips of the fingers on the sacrum, and pads of the fingers on the medial PSIS. Should be here. So now we'll have the patient's involved leg in a neutral position relative to the adduction arc of the knee. So the doctor swings the knee medially, and the PSIS should open away from the sacrum slightly. And if not, it's an IN ilium. Doctor returns knee to neutral position, and then the doctor will swing the leg laterally. If it closes, it should close toward the sacrum slightly. If not, it's an EX ilium.